SBU is the Spina Bifida Association's new viral education program. Our goal is to bring the world's best care providers and resources directly into your home. SBU is the only free webinar series dedicated solely to the educational, employment, social, self-advocacy, and health needs of people with spina bifida. We hope that you will enjoy this presentation. Academics and attention. Executive function in spina bifida, school age into adulthood, and that you will take the time to complete the evaluation at the close of this presentation.
Okay, well, it's my pleasure to introduce Dr. Marcos de Pinto, who is currently a pediatric neuropsychologist at the Children's Hospital of Orange County. So is that just in the backyard here, or where is that? Yeah,
that's right in orange.
Right in the orange, right in the OC. Yeah, and before that did a postdoctoral residence with an excellent oncology researcher at St. Jude Hospital, and still maintains interest in oncology and developmental disabilities. And really, his greatest claim to fame is being one of my graduate school colleagues, right? Is that so? Marcos and I both went to graduate school together. Actually, I would say your current status outweighs that at this point. So please welcome Dr. de Pinto.
Okay, thanks for having me. I'm going to lower this a little bit because I'm not quite as tall as Dr. Zabel. So I'm going to try to present more of a broad overview of academics and executive functions in spina bifida, focusing more on school age into adulthood. So I'm not going to go too much into the specifics regarding too many specific interventions because that's going to be discussed in more detail later on. I'm also, just to let you know, I'm going to draw some inferences from a few other clinical populations that I think we can make some really nice parallels in terms of helping understand some of these models and their application for spina bifida. So just briefly, we will review a model of executive function. We'll also look at the relationship of executive functions and academics. We'll review a couple quick clinical screening tools of executive function and academics that would be potentially very good tools for spina bifida. We'll also talk a little bit about the developmental trajectory over time. So what happens as children age in terms of executive function skills, how they interact with the environment, and academic outcome. So executive functions, it really encompasses, and it's an umbrella term encompassing interrelated skills necessary for purposeful, goal-directed activity. And the term actually, the descriptor for executive functions, in part came from what does a corporate executive need in order to be successful, right? So it's not just being intelligent, but you need to be able to be efficient. You need to have good organizational skills. You need to have good time management. So all of these things are critical aspects of executive functions, which leads me to a funny story. I was explaining this to a child I just tested that was in the 6th grade, and mom said, "But my kid's not a corporate executive." And I said, "Well, you know, every corporate executive was a 6th grader at some point." So, okay, so this is one model that's used to describe the different domains of the executive. All right, so these are 8 different subdomains, initiation, working memory, inhibition, being able to shift from one task to another, organizing, self-monitoring, and emotional control. So some of these are actually, if you look at these skills that are involved in these subdomains, you can actually link them back to some of the things that were described in the talks earlier. So for instance, being able to monitor what you're doing from 1 second to the next. It seems that this could potentially be an explanation, at least in some cases, of maybe some of those counting errors that we were talking about earlier. It was 1, 2, 2, 3, 4. So that not being able to correctly monitor and kind of keep track of what's happening is an important executive skill. Also working memory. And working memory is a little bit of a hard concept to grasp sometimes, but it's that ability to keep online multiple units of information and manipulate them at the same time. So, if I gave you a number to remember, or if you had 5 or 6 different units of information that you wanted to organize and arrange, for instance, in writing a small paragraph or a paper, your working memory would really be online for that, and having to organize and sequence that information. So there's some pretty important skills. So one nice analogy that we use to help us understand this is that of the conductor and the orchestra. So really, if we look at a lot of the basic cognitive processing skills that we have, language, memory, our sensory inputs, basic vocabulary and lexicon, these things can be all intact, but we need to use all of those executive subdomains to be able to efficiently organize and manipulate that information. So there are a lot of nice parallels with this and what Dr. Zabel was talking about earlier with the assembly kind of processing. So some more of the basic processes are intact, but being able to sequence them correctly, being able to make inferences, being able to remember that on planet Gan, they make fur out of cute blue bears. So, things like that, remembering that and kind of carrying that over to the reading comprehension and making those inferences, it's going to depend on that working memory. So, in a way, we're looking at the executive as being the conductor of the orchestra, and producing that harmonious music would basically be producing goal-efficient behavior. Whereas if you don't have a very good conductor, you're going to have some pretty bad music potentially. So one thing I did highlight here is that's a little bit unique to the Spina Bifida population is the fact that there are some motor issues, right? We talked about the cerebellum, and the cerebellum is also involved in visual scanning. So sometimes, I would imagine that there could be some visual scanning issues or fatigue, also with that graphomotor output. So these are things that are staggered on top of some potential executive function difficulties that may exist in the Spina Bifida population. I think it's also an important thing to recognize in that sometimes the orthopedic issues are more salient or more visible. So they may mask some underlying executive function issues just because the other ones might take more immediate precedence, on the day-to-day situation. So these are some frequent problems that are impeding academics. Disorganization, can't remember 3-step instructions, poor planning, failure to write things down, not being able to have the right materials to start projects. So these difficulties are present despite normal general intellectual function, basic verbal language and communication skills like we talked about in the Spina Bifida population. So what's going on here, right? We have normal IQ, we have some normal basic skills that we would assume would be necessary to achieve at grade level. But it really may be due to an inefficient application and regulation of these other core processing systems. So this is a really nice model that's used by DiPerna and Elliott. They're school psychologists, and they looked at academic competence as a function of two domains. One is just the basic academic skills, right? Having your reading, your mathematics, critical thinking. And then they also encompass these other 4 academic enablers or behaviors, so study skills, interpersonal skills, engagement, motivation. And a lot of these 4 smaller red boxes, which have these academic enablers, do have a nice overlap with executive functions, right? So study skills are things like, are you handing in your homework? Are you completing that consistently? Are you checking your work for mistakes? Are you careful? Engagement, are you asking questions if you don't understand? Are you paying attention? So But the nice thing about this model is that it's really looking at these behaviors within the school setting. So specifically within the classroom and within the school setting, which is sometimes something that we have a little bit of a harder time getting direct access to when we're working from an external clinic. So it can provide a nice picture to kind of round out what's actually happening both in the school setting and both in the home setting. I'll talk more about this questionnaire and this model later. So I'm going to, again, make an inference now, like I discussed earlier, with another clinical population with executive dysfunction. So these are kids with ADHD. I examined 4 different variables to really try to look at what's going on with these children, in that a lot of them have normal IQ. They don't necessarily have too many really specific learning disabilities. So what's happening? How can we use this model of executive function to help us understand the discrepancy between the performance and their ability level? So I looked at IQ, and I also looked at individually administered performance-based measures of academic achievement. So these are actual tests that we give the kids, looking at their word decoding skills, their spelling skills, their basic math calculation skills. And then I used that other model that I just posted up here with the ACEs, academic competence evaluation. And this is a teacher rating of academic skills. All right, so this is really interesting because it basically asks the teacher to rate that child's skill, compared to the average child in your, or average expectation or performance level in your classroom. How does this child rate on this particular skill? At grade level, above grade level, far above grade level, below grade level, or far below grade level. So it's looking at those same skills in those individually administered performance-based tests, but it's an actual teacher rating of that. And then there's also the teacher rating of these academic behaviors, so things like the motivation, study skills, and so forth. So, and this is kind of what I found here. We can see on the left right there, we have the standard scores for all the different tests and measures that were given. So 100 would be average. And then on the bottom, we can see all the different domains that were looked at. So we have the full-scale IQ. And then I actually have the Y2, which was the individually administered performance-based measures. Then I had the teacher rating of these skills, and then I had the academic enablers. So what we can see here is a pretty significant decrement, right, in actual performance. So IQ is okay. And actually, a lot of the academic achievement, real basic academic achievement skills, can be okay sometimes, and they're within normal limits. And then we see a drop in the actual teacher rating of these same specific skills. So why would the teacher rate the skill as being necessarily lower than what it would show up on an individually administered performance-based task? And then with academic enablers, we see another drop. So really what this is demonstrating is that even if that skill set might be there is not a consistent or effective application or demonstration of those skills, day to day. So a child may know their math calculation or times table facts one week, but then the next week they seem to have forgotten, that skill, or they're not doing it very quickly or very efficiently. And so I think that's what this is really picking up, and it's kind of demonstrating that nicely. So children with spina bifida face numerous barriers that may limit their ability to stay actively engaged in academic instruction compared to their peers. One issue being a lot of the orthopedic limitations. And then there's a lack of efficient and effective application of these core academic skills. So the disorganization, having poor study habits, significant difficulty planning ahead, and poor estimation of the time necessary to complete tasks. These are all things that can draw away from the ability to function or produce at a level that you may be capable of, given some of the core basic skills that could still be present. So one of the measures that we use to look at executive functions is called the Behavior Rating Inventory of Executive Function. So this is a questionnaire designed to assess the behavioral everyday manifestation of executive function difficulties. And actually, in that prior study that I showed you, the brief was able to account for up to almost 40% of academic function in all of those different measures that I looked at. So even in the Wyatt-2, in the teacher ratings of academic performance, and also the academic enabler. So basically, the reason I'm indicating that is that there is not only a theoretical link between the executive functions and academic performance, but there's actually a real world prediction value, right? Because sometimes we're in our own bubble of this measure looks at this and that, and it's supposed to relate to that, but does it? I mean, does it actually correlate or predict or give us information that will be clinically useful? And so far, some of the preliminary evidence in looking at this questionnaire for clinical populations with executive dysfunction is that it does. So it might give some good insight into whether or not a child is at risk for academic problems, especially when there are other things that might not be apparent, right? If the IQ is normal and if some of these basic, word decoding skills are normal, how can you tell if a child is going to struggle, right, or have these difficulties? So this is a really nice screening tool that can be used to give us some information on that. There's multiple versions of this questionnaire. There's a parent form, teacher form, there's self-report forms, and they also span all the different age ranges. So we have probably the most commonly used are the parent and teacher forms for ages 5 through 18. There's also a preschool version for ages 2 through 5. There's the self-report version for 11 to 18, and then there's an adult self-report form. So there's plenty of briefs out there for all ages, people. Okay. It consists of approximately 86 items. Each item asks the respondent to rate the presence of a specific EF behavior as occurring never, sometimes, or not never again, but or often. So that's a typo. My executive functions were not working when I was writing that. Okay. So some sample items include need to be told to begin a task even when willing, and that would be something that would fall under that initiation domain, or backpack is disorganized. Starts project without the right materials. So these items are organized into 8 scales and 2 primary indices. And so the 8 scales represent the various EF subdomains that we talked about earlier that we reviewed, like the initiation, inhibition, working memory, and so forth. There's a little bit of variability in these scales in that the preschool version, it's pretty much follows the same format, but maybe 1 or 2 of the scales are slightly different. So this, and Dr. Zabel has actually done a fair amount of research showing that this questionnaire is very sensitive in detecting executive function difficulties among children and adolescents with spina bifida. So it is applicable also to this population, and it does have a high degree of sensitivity in picking up some of these executive function difficulties that we're talking and discussing. And then again, as I mentioned earlier, some of the preliminary research has shown the brief to be highly predictive of academic function in other clinical populations with executive dysfunction. Kind of interestingly, for the inattentive subtype of ADHD, these 3 scales were the scales that were actually found to be the best predictors of academic problems. Okay, and for the combined subtype of ADHD, I found those scales underneath there to be most predictive, and they accounted for almost all of the variance that I found for academic function. So it's again another potentially clinically useful way to interpret or look at this scale, this questionnaire, because again we have our ideas in theory of what is supposed to be linked with what, but what actually does measure the academic function. Interestingly, with the children with the inattentive subtype of ADHD, so these are kids that don't have that real extreme hyperactivity component, but they do have the problems with the inattention. The initiation was found to be the best predictor, but primarily for the teacher report. So I think this sort of highlights another really interesting aspect of the fact that we're getting two sets of information when we're looking at a parent report versus a teacher report, and oftentimes there's some real specific behaviors that are going on in the classroom that are critically linked to academic performance or outcome, but we might not see that in the home setting or in other places. So, you know, initiation of doing your chores might be might not be as quite of a clear link with academic outcome, right, in the home setting, versus not taking that initiative of doing, you know, your classwork and your schoolwork in the school setting. There could be a stronger link for that. So it does kind of highlight the importance of really pulling in, if possible, information from multiple settings, from different providers. And the other scale is the academic competence evaluation scales, the teacher ratings. I think this is just it's not I think too well known of a questionnaire within the neuropsych community, but it's actually a fantastic questionnaire, and I'll talk about it a little bit more why. So this assesses academic skills and enabling behaviors for students in grades K through 12 in college. It's a teacher rating questionnaire of academic skills primarily. There's a self-report form, but for the purposes of our clinic, we use the teacher rating. And again, it's actually asking the teacher to rate these specific skills of reading and language, of mathematics, and of critical thinking, and it breaks it down into a very specific manner. So word decoding skills, reading comprehension skills, you know, basic math calculation, spatial reasoning ability, solving math word problems, right? Each of these are a different aspect, a very different specific aspect of these academic skills, and you actually have that teacher rating, and then it also looks at those academic enablers. So, and this is a great tool to have when you're setting up an assessment, a neuropsychological assessment, because sometimes the parents aren't completely accurate or sure exactly with what is happening, right, or what's going on. And in my practice, I deal a lot with bilingual families and with parents that only speak Spanish. And in those instances, sometimes they're often pretty disconnected from exactly what's happening. How can they really evaluate what weaknesses they have in English when they don't speak English? So having this rating scale with these real specific you know markers of what are these academic weaknesses can really help plan that assessment much more efficiently and being able to dig out those areas of weakness. So the demands on, we're going to kind of transition over here a little bit now to the developmental trajectory of executive functions and the implication on academics. So the demands on the executive function skills typically increase with age, right? We have less structure, there's an expectation to function more independently, less oversight, there's more long-term planning and organization. So therefore, individuals with spina bifida are potentially more vulnerable to experiencing greater academic difficulty with increasing age. Right? So as the environmental demands exceed the capacity to keep on top of everything and keep organized. This is just a hypothetical graph where we're showing with increased age the demands. So the yellow arrow are kind of increasing over time. And some of the inherent support structures that we have in the environment tend to get reduced as the expectations transition for that child to function more independently or autonomously in the environment. So the critical issue is where does that intersection take place, right? That ability to be able to meet the demands in the environmental setting at that time. So the clinical presentation for something like this may include a seemingly abrupt or sudden onset of academic difficulty. So, you know, everything seemed to be going okay for my child, but things fell apart once they entered high school. I'm not really sure, you know, exactly what happened, or it could have been from, you know, grade school to middle school that there seemed to be just a sudden decline or drop in that academic function. However, upon closer inspection, often this abrupt onset of these academic difficulties occur at key transition points. And these are key transition points that if we think about that chart earlier, where there's that overlap between the demands of the environment and what that child or individual is able to produce at that time. So these transition points are typically characterized by a stepwise increase in demands placed on the executive function system. Okay, so awareness of these critical transition points can help providers identify when individuals with spina bifida are more likely to experience academic difficulty. Okay, so examples of such transition points include, but are not limited to, that transition from grade school to middle school, from middle school to high school, and from high school to college. So using the executive function model, we can have some better concept or idea of where are these critical junctures of vulnerability that are likely to take place, where the demands on the executive function system really take a big jump, and the structure and accommodations and assistance that would need to be in place to allow that person to function at that level are not quite there yet. So the clinical implications include a more aggressive screening and vigilance closer to the time of such transition points. So something as simple as even using that brief questionnaire or using the ACEs, the Academic Competence Evaluation Scales, might provide a really nice opportunity to say, you know, these are pretty elevated, even though the child is performing okay. If there's going to be a big transition, either to a new change into another school or a big jump in grade level, we may need to look into providing maybe some tutoring or some extra assistance or help, because there's a higher likelihood that there will be some difficulties following this transition. So I'm going to, further compounding these difficulties, more recent research has found evidence of white matter abnormalities in children with spina bifida. So this was a study that compared 38 children with spina bifida and also had a control group matched by age and gender. Okay, I'm not going to get into too much of the nitty-gritty, specifically, you know, the biology of the study, but they used diffusion tensor imaging, and they revealed abnormalities in both the microstructural and macrostructural levels of white matter. So as the brain develops, there are white matter pathways that become more solidified and richer in terms of their myelination and synaptic connections with other areas of the brain. So this is something, when we're looking at the phylogenetic development of the brain, and also just from prenatal, perinatal, you know, early childhood to young adulthood, white matter continues to develop. So this is something that that is actively developing even up until, you know, adolescence. So it's something that can be affected by different kinds of medical treatment. And it can be vulnerable to a variety of different CNS-related, you know, insults or complications. So this is kind of an important finding. The other really important, or really interesting for me at least, aspect of this study was that it found evidence of abnormal white matter development with increasing age in the spina bifida group. So the implications were of reduced myelination in the white matter tracts and increased vulnerability to deterioration in axonal microstructure. So, you know, we talked a little bit earlier about what are some of the primary, you know, CNS issues, the Chiari-2 malformation, some of the cerebellar, you know, abnormalities, but also that white matter is developing potentially abnormally or differently. You know, through early childhood. So that's a pretty interesting implication as to what that means and how this could affect learning. Now, models of disrupted or abnormal white matter development also exist in a number of other clinical and medical populations, particularly pediatric oncology. So I'm going to draw a few inferences from the pediatric oncology literature, and I think it might bring some insight as to what are some underlying things that may also be applicable or happening in spina bifida. So the neuropathology in regards to late effects for the pediatric oncology population, at this point, it may be related to, again, the disruption of the normal white matter development in the brain. But the really interesting thing is that in early childhood, the rate of white matter growth and new development is really explosive. Okay, so it tends to occur very rapidly, and it's almost a curvilinear model of what's happening. It's not just this gradual, linear increase in the white matter. There's this explosion, and then it tends to kind of plateau and curve out a little more, but it still increases, through age. So, these different colors are basically showing different white matter pathways that are developing, and we have the age in months below, and then on the side we can see the percentage of white matter development. So again, that follows kind of a curvilinear pattern. So what we find actually in the oncology literature is that children treated at a younger age are at greater risk for neurocognitive and academic disability, because what's actually happening is that you're disrupting that white matter development at an earlier stage, when there's still a lot more that has not been produced yet. A lot of white matter tracks that have not been solidified and formed. So if we draw an analogy too, again, there are a lot of potential CNS-associated complications that can take place in spina bifida, and I would predict that if there were a lot of complications that took place at a really young age, that there might be some greater likelihood of problems, in part because of what we're seeing here in our knowledge of how white matter develops and the course in the brain. And then to further emphasize this link between white matter pathology and development and outcome, there are quantitative MRI studies that have found a significant association between white matter volume integrity and neurocognitive outcomes. So that with more white matter dysmorphology and abnormalities, there are links with worse neurobehavioral outcome. So it's, again, we're actually linking data to theory, right, of what's going on. So this is an important aspect of that. So therefore, there are multiple factors that are contributing to the developmental trajectory of learning and academic function in spina bifida. So these include identified weaknesses in executive function, white matter development, and so these factors can result in a reduced learning curve, which becomes more visible over time as that learning gap increases with age. So we're looking at both executive function, also in combination with some real specific, neurological correlates that are specific to spina bifida, right? So this is again a kind of a theoretical curve that I sort of or graph that I put out here, but again, there is data supporting this, and I'm going to talk about this in a second. So oftentimes what we see for these children that have some white matter abnormalities is and especially for the pediatric oncology population, following treatment, is a reduction in their rate of new learning or acquisition of new skills, or that automaticity or efficiency in applying these skills. So and one analogy that I use is imagine having something that affects your height. Let's say we have a child that's in the second grade, and they're have some kind of treatment that is affecting their growth or their height. Are you going to see a change? But before that, they were growing normally, developing normally, they're at normal height. If you start that treatment or that medication that's going to affect their future growth and future height, you're not going to see anything the next month, right? They're going to look the same height as their other classmates or peers. But the next year, they might be a little bit shorter, right, than their peers. But again, it's not something that's going to be that discrepant. But after 3 or 4 or 5 years, you're really going to start noticing, this child's not growing, and they're much shorter than where they should be in terms of that developmental trajectory or profile. And in a way, we need to remember that learning, even IQ, memory, attention, all of these are skills that you need to improve and get better at over time in order to stay at that developmental trajectory or normal profile. So to stay at the 50th percentile for height, you actually need to grow a little bit each year to stay there. And it's the same thing with IQ. It's the same thing with these other skills and functions. So I think it's actually a really nice potential just a way of looking at it, and an analogy that can be used to help explain what might be going on in terms of that developmental trajectory over time in terms of learning and acquisition of new skills. And so again, we have both the executive function component to it, and we also have some specific neurological correlates that we're learning more about in spina bifida that could also be either compounding or contributing to some of these issues. So just briefly in terms of summary and conclusions, children with spina bifida are more likely to exhibit executive function difficulties. The greater degree of CNS involvement, abnormalities, and complications are associated with an increased risk of academic and adaptive problems. And models of executive function in conjunction with the neurodevelopmental correlates of spina bifida can really help facilitate our understanding and knowledge of academic problems in this clinical population. We also reviewed specifically the behavior rating inventory of executive function, the brief, as well as the academic competence evaluation scales. So these represent potentially useful quick screening measures to identify individuals in this population that are increased risk of academic difficulties. And really the idea is that by doing these quick screening measures and tools, we might have more of a window of opportunity to deliver earlier preventative intervention, because the whole idea is to try to identify children that are at risk maybe before they really start struggling or doing poorly at school. And these are questionnaires that can be pretty easily administered. They take about 10 minutes to complete, and they've been shown to be sensitive in picking up executive function difficulties in this clinical population, and we also demonstrated some pretty clear links with how that can be involved and predictive of academic performance. And then we also discussed how, in regard to that developmental trajectory, that children with spina bifida may be more vulnerable to academic difficulty with increasing age. Given the interaction between executive functions and the environment, these difficulties are they may be more likely to manifest during key transition points. So, and again, these principles can help with the screening and identification of those at greater risk and help deliver that earlier intervention. So that is the end of the presentation. If there are any questions, I'd be happy to answer them.
Hi, thank you for that. Can you talk a little bit about whether or not there were differences demonstrated with respect to the trajectory of learning difficulties in shunt versus no shunt? And also, when you talk about spina bifida, are you talking specifically about open neural tube defects specifically, myelomeningocele?
Yeah, I am. That's correct for that latter part. I'm not as familiar with all of the shunt revisions, so I'm going to ask Andy to help me answer that one. But I can tell you for pediatric, for neuro-oncology and oncology population, that there is increased risk for neurocognitive side effects with more surgical complications, with more shunt revisions, because basically what that's indicating is that the hydrocephalus is not under control, right? It's not stable. It's there's this constant intervention that needs to be take place to help manage that and control that. And each time that happens, just depending on the degree of hydrocephalus that may have occurred in the interim, that can always produce some effect in terms of stretching, the neurons and the axons causing a little bit of tearing. There's always that increased risk for infection when you're going in there and you're doing another shunt revision. So there is a link with that in oncology, and it kind of falls under that general umbrella just of the more complications, the higher likelihood you have of risk and just that management of hydrocephalus. But in terms of the long-term kind of outcome and in learning, some of the stuff that I'm talking about. I know that takes place in the neuro-onc population. I'm not too familiar if that exact same kind of profile or curve takes place in spina bifida. I would imagine in some cases it does, but maybe Dr. Zabel has something that he wants to add for that.
I can add real quick. The overwhelming majority of research we have on this is in individuals that have shunted hydrocephalus. And yet the surgical procedures are now changing, and while we used to have a very high rate of shunting, we've ratcheted that way back in terms of the management of hydrocephalus. So we haven't, I think, had the opportunity to look at those trajectories to the extent that we do now, with far more kids with spina bifida going unshunted and having, their hydrocephalus at least compensated, if not arrested. So I think we'll see that coming up. It's a great question, but I don't think there's a good answer.
Thanks. Thank you. Uh-huh. Yes, I forgot to mention that. It exists in like 80-something gazillion languages, so you can find it in pretty much any language, unless it's some really esoteric language from some, tribe in the rainforest or something. You'll find a translation for it. So, and it's the brief, yeah, the behavior rating inventory of executive function. There's multiple translations in different languages. So it's in Spanish. It's in I don't know, every language you could probably imagine. It's been translated to. So, uh-huh. Yeah, I do, because what happens is that a lot of times there's difficulty in terms of the families knowing what's going on, right? They don't seem to be learning. Is it a memory problem? Is it attention? Is it that they're having a reading disability? But then when we go through all of the neuropsychological assessment and procedures, we often see that some of these core skills are there, and some real basic memories there. The word decoding is there. Basic math calculation skills can often be there. Sometimes they're not. I mean, clearly there's a higher risk for some math disability, but in the cases where there's not too many real specific, isolated, deficits, it's hard to know what exactly is contributing to this gap, in academic performance. So when you can really demonstrate that and show that with using good thorough assessment of executive functions and make that clear link to how that is affecting memory, right? If you're not effectively paying attention, if you're not monitoring what's being said, if you're not reproducing things in the right sequence, it's going to look like you're not really remembering things accurately, but it's really that inefficient application, right, of these other core systems. And then so I think it helps bring peace of mind a little bit to families, because they might not know that there's not some other real specific problem going on, and at least some clarity as to what's going on, and then where to focus the energy of the interventions, right, of what to do and where you're going to get that maximum benefit. Uh-huh.
With the pediatric oncology population, we know that late effects typically manifest a couple years post-treatment. Mm-hmm. So do we have an idea with the spina bifida population about onset, or is this something that we're saying is, kind of immediately from birth?
That's a really good question. I think that's something that again, I'm going to ask Andy to help answer that. Also, to keep in mind that that's technically the definition of late effects, is that you see these problems 2 years post treatment, and sometimes you will get like a new onset of something that happens several years after treatment. For instance, kids that get radiation therapy to the brain, sometimes they lose their hearing 5 or 6 years, up to 3 or 4 or 5 years after they finish treatment. So it's something that takes place. That radiation, could affect that hearing later on. But sometimes there are things that are happening right away, even right after treatment, but you just don't see them until later on. And again, if we bring that analogy back to the height, right, you're not going to necessarily see that right away, even though it may already be in place and actually happening right there. So I think there's two dimensions to the late effects. But I don't know, Andy, if you have any information regarding. Yeah. Yeah, I think what Dr. Zabel is basically saying is that in regard to how this manifests in that trajectory, that when the environmental demands really take that stepwise kind of jump or increase, that's when you're likely to see the manifestation of some of these difficulties. And so another analogy too is if you actually look at kids with dyslexia, with actually classic reading disability, they learn in some regards some of that aspect of the communication skills are there. They learn to orally communicate, but you actually don't see that reading disability really clearly until it becomes closer to the time when they learn to read, right? But this doesn't necessarily mean that never existed. That reading disability, from the research that we know, as they're born with that, it wasn't pulled for from the environment, so you don't see it until that time point. And I think some of these difficulties, it operates in the same manner. You're not going to see that until it's pulled for in the environment.
There's research in how geriatric patients are impacted by oxybutynin. Do we have is anyone doing research on oxybutynin and children and how that impacts the learning trajectory of disabilities?
Okay, I'm gonna have one of our guest speakers here answer that question.
The short answer is I'm not aware of any research related to spina bifida and the use of oxybutynin at this stage as it relates to neurocognitive functioning. I haven't seen anything. It's a very interesting question, but I haven't seen any research.
Sorry, but I'm glad we have a whole panel of experts here, because there are going to be some questions that I'm not going to know the answers to, but we can help answer this. And yeah, these are great questions. And I know this is a lot of information that was presented, and I spoke a little quickly, so hopefully you're able to absorb some of what I said.
Thank you for attending this session. Because meeting your needs is important to us, we need your feedback on the presentation. Please take a few moments to complete our evaluation, which can be located by clicking on the presenter's name located to your left on the screen. It will only take a few clicks of your mouse to provide us information to make the SBU experience better for you and others. If you have any questions relating to SBU, please contact us at sbu@sbaa.org.